the policeman or this guy's Russian? If they learned their lesson, because in 2004 Ukrainian police wouldn't get citizens. And so they disguised Russians and then they went to Crimea and then they started to help them. And actually, you know, if you see your politician who supports Russia, you can absolutely be sure that they deserve their wrong. No one supports Russia.
Or Russia has something to do with
Yeah,
that as well.
yeah, because people say like Trump is their agent, but I don't think he revealed himself. Let's be honest, there's everything in the news and his violence.
Шановні колеги, прошу займати місця. Потихеньку ще 5 хвилин дамо до тих, хто не доспав неділю після тривоги. Будь ласка, займайте свої місця тихенько. Технічний момент. Хто ще не взяв навушники для перекладу? Будь ласка, якщо вам вони потрібні, то зараз це зробіть. Дуже приємно бачити половину залу без навушників. Це означає, що рівень C7. Добрий день, шановні пані і панове. Давайте ми перевіримо наші навушники. Докторе Лизак, ви нас чуєте, так? Який канал в нас з англійської в українську? Окей? What channel it is? English? Yeah, but what's number? One, yeah? Okay. А тепер з української на... How are you today, guys? Чуєте? Хто не чує, підніміть руку. Ви не чуєте, так? А ви в навушники вдягніть. Окей. Ви чуєте, так? Добре. Ну, гаразд, тоді ми готові сьогодні працювати. Добрий день, шановні пані і панове. Мене звати Олег Березюк. Я лікар-психіатр, психотерапевт, керівник служби ментального здоров'я першого ТМО, асистент кафедри психіатрії і психотерапії Львівського національного медичного університету. Ми раді вітати вас в першому ТМО і в центрі UNBROKEN на сьомому семінарі, школі вивчення посттравматичного стресового розладу та розладів, пов'язаних з військовою травмою. Дуже дякую, що ви витрачаєте свій час і сьогодні разом з нами і з нашими колегами. Хочу сказати історію цього всього. Все це почалося в перші дні початку повномасштабного вторгнення, брутального вторгнення Росії в Україну. І до нас проактивно звернулася професорка мистецтв Єльського університету і сказала, чим ми можемо бути для вас корисні і помічні в вивченні психологічних травм війни. Це була професорка Марта Кузьма, яка і по великому рахунку заснувала і ініціювала школу вивчення воєнної травми. І ми дуже вдячні, що мистецтво, власне, розпочало наш шлях до пізнання цієї травми. Марта Кузьма зараз є також у Львові, можливо, і завітає до нас. Тому дуже дякуємо. Але Марта Кузьма познайомила нас з чудовими людьми, які вже 7-й раз з нами працюють, досліджують. І кількість цих людей, ця команда, яка разом з нами працює, навчає, комунікує, дискутує, вона щоразу збільшується. І тому сьогодні я буду мати велику честь з вами їх познайомити. Декілька вступних слів, чому ми тут, ви, напевно, знаєте, але я завжди повторюю, що виклики, які у нас перед нами є, це виклики, які не змінюються. Це виклик кількості людей, які потребують і потребуватимуть допомоги, та виклик важкості. Так? Важкості травми, важкості перебігу, важкості впливів на життя, на якість життя, на суспільні відносини. І це наші з вами виклики. З'явилися зовсім нові цифри останнім часом. Мій колега з кафедри Олег Федькало поділився з ними, і я ділюся з вами. Зараз в Україні налічується 1,3 мільйони ветеранів. Тобто цих людей, які вже звільнилися з війська і живуть в цивільному житті, але є військовослужбовцями. А якщо ця війна не припиниться, це очікування, що ветеранів буде 5 мільйонів. Хочу вам сказати, що це є 20% від популяції України. А якщо додати до цих 5 мільйонів ще родини, це виходить 30% популяції України. То майже 1/3 населення України потребуватиме нашої з вами підтримки. Серед них є і ми з вами. Дослідження глянуло, які проблеми після повернення визначають самі ветерани. У них є. 59% з них сказали, що найважливішою проблемою є нерозуміння суспільства, їхніх потреб і їхніх переживань. І ми, працюючи вже 3 роки, бачимо, що це один з найбільших викликів, на який ми з вами не дуже звертаємо увагу, бо, можливо, і не бачимо його. 57% сказали, що це проблеми з здоров'ям загалом. І ми це бачимо з вами, що по великому рахунку, в нашій лікарні це очевидно, 99% це ті, які мають різні проблеми з різним фізичним здоров'ям. 53% говорять про те, що їхньою проблемою є психоемоційна нестабільність. 52% – це безробіття і неможливість влаштуватись на роботу. 43% кажуть, що алкоголь і вживання наркотичних речовин є їхньою проблемою, яка забороняє їм або не дає їм якісно інтегруватися в мирне життя. І 42% кажуть, що конфлікти в родині і нерозуміння родини є їхньою найбільшою проблемою. Ще дуже є багато інформації, але я вибрав тільки тих 3 аспекти. І третій аспект є те, що заважає ветерану або ветеранці інтегруватися, або знайти, не інтегруватися, а знайти роботу, або працевлаштуватись. І тут 3 головні проблеми є. 28% кажуть, що це погане здоров'я. 26% говорять, що це погане психічне здоров'я, психоемоційний стан. І 18% кажуть, що вони втратили свої професійні навики. Це все наша з вами робота. Ми маємо бути тими асистентами, помічниками, друзями, колегами, лікарями, які допоможуть людям знайти себе після впливу, жахливого впливу воєнної травми. 7-й семінар є дуже важливим для нас. На минулих семінарах ми заглиблювалися в серйозні проблеми ПТСР, роботи з пацієнтами, що пережили тортури і полон, з коморбідною патологією. Сьогодні ми глянемо на це ще раз. Так? Серед нас є багато різних людей, які не були разом з нами. Заглянемо в глибину патогенезу, етіології, перебігу, розуміння посттравматичних стресових розладів, зокрема ПТСР. Ми глянемо на те, як лікувати ПТСР, зокрема психотерапевтичними методами. Ми глянемо на один з найпоширеніших і найефективніших методів – це експозиційна терапія. Але найважливіші речі, які ми на цьому семінарі будемо пізнавати, і це була нашою прогалиною, таким чорною плямою поки що в наших знаннях або нашій впевненості, це 2 теми. Це тема моральної травми, яку ми почали бачити, стараємося розуміти, і тому ми поговоримо цього разу про моральну травму і про суїцидальні ризики, які, на превеликий жаль, все більше і більше з'являються в полі нашого зору. І третя частина, яка не буде стосуватися більшості з вас, це нейронауки. Ми продовжимо, починаючи з минулого нашої зустрічі, продовжимо пізнавати, вивчати транскраніальну магнітну стимуляцію. Ми будемо доторкатися до аналізу функціонального МРТ, з яким ми почали працювати. Тобто це наш план на цю школу. Але тепер я би хотів сказати, хто нас сьогодні буде слухати. Це неймовірно цікава група людей, яка сьогодні сидить в залі. Я маю велику честь подякувати за те, що практично на всіх наших школах присутня Військово-медична академія України. І я дуже дякую колегам з Військово-медичної академії, які з нами разом вчаться і стануть нашими партнерами. Сьогодні це особливо є, крім завідувачки кафедри Академії психіатрії і психотерапії. У нас є найдорожчі люди. Це інтерни цієї кафедри, які разом з нами працюють. Дівчата і хлопці, дуже важливо. Це військові лікарі майбутні і психіатри. Хочу вам сказати сумну історію, що кафедра психіатрії була створена в Військово-медичній академії в 2022 році. Це говорить про постколоніальний синдром, який до сьогоднішнього дня захоплює наші голови. Але ці люди – відважні люди, які пішли і зробили це. Дуже вам дякуємо. Це центральний госпіталь Міністерства внутрішніх справ. Вони вже 3-й раз працюють з нами. І це люди, які дбають про здоров'я поліції, Національної гвардії і, без сумніву, багатьох інших людей, які працюють, допомагаючи ДСНС. Дуже вам дякую за це. Нові наші колеги, які звернулися до нас по співпрацю, це колеги з Центру пробації. Багатьом з вам Міністерства юстиції України, багатьом з вам навіть це слово не знайоме. Але на превеликий жаль, будуть військові, які наші герої, які з тих чи інших причин, в тому числі з причин посттравматичного переживання, будуть вчиняти ті чи інші неправомірні поведінкові речі. Бачите, мені навіть не хочеться говорити слово «злочин» по відношенню до цих людей, але так і буде. І українська держава активно вже 10 років впроваджує систему пробації, тобто не ув'язнення, а пробації. Вам дуже дякуємо, що ви разом з нами і будете думати. Критичні важливі люди, так, поліція, військові та юстиція, розуміння, всі ці служби створюють свої потужні психологічні підрозділи, які вчаться разом з нами. Дуже дякуємо вам. Наступні люди, які можливо найважливіші, це є психологи шкіл. Адже ви пам'ятаєте, 30% разом з родинами. І ці батьки або матері, які повертаються з фронту, вони будуть комунікувати зі своїми дітьми, і ці діти будуть приносити це в школу. І, можливо, першими діагностами складної психічної травми в родині будуть вчителі і будуть шкільні психологи. Тому я дуже дякую освіті за те, що сьогодні тут є люди, які дбають про наших дітей, але ви ж точно будете дбати про їхніх батьків. Тому пізнання в цій галузі є критичним для вас. Наступне – це є психологічна служба соціальних служб. Неймовірно важлива річ при такій кількості людей. Тому також дякую, що ви разом з нами. Ну і найважливіше – це є лікарі-психіатри, психотерапевти, психологи, клінічні психологи, які працюють в різних лікарнях, в різних центрах ментального здоров'я, які сьогодні прийшли професійно підвищити свою кваліфікацію. Дуже важливо те, що держава побачила і зараз масштабує досвід першого ТМО в створенні центрів ментального здоров'я в багатопрофільних лікарнях. Сьогодні ці люди, які прийшли сюди, в тому числі є психіатрами і психологами тих центрів. Для вас це дуже важливе навчання, після якого ви будете більш ефективніші. І найголовніше, серед нас є люди, яких ми ніколи не працювали, а це, зокрема, священники і працівники богословських академій, як і Львівської, так і Волинської єпархії. Я дуже дякую асоціативному професору, члену нашої кафедри, доценту Кирилюку Сергію. Пане Сергію. Та також представникам Волинської академії, де ви є, дівчата. Дуже раді вас бачити. Це ваш день, бо моральна травма є нашою спільною проблемою, і ми мусимо шукати інструменти впливу на це. Тому я дуже дякую вам, що відгукнулися на це і починаєте шлях разом з нами пізнання цього. Тож, це ті, хто нас будуть слухати. А тепер це ті, яких ми будемо слухати. Ілан Гарпа з Ротем. Ви його вже знаєте. Ілан є професором психіатрії і психології Єльської медичної школи. Ілан не просто наш ректор і вчитель, Ілан є нашим другом, який взяв на себе велику відповідальність, соціальну відповідальність нести на своїх плечах школу воєнної травми в Україні. Ілан, дуже вам дякую за це, за цю жертовність, і ми будемо сподіватися, що наша школа, спільна школа, буде корисна для інших. Ілан є дуже важливий для нас, тому що він не просто професор, Ілан є військовослужбовець, так, був військовослужбовцем і пережив це на своєму власному досвіді. Тому його досвід, як науковця і військового, для нас є дуже важливий. Дякую, Ілан. Новий член команди школи військової воєнної травми – це професор Соня Норман. Соня є нашою колегою і є професором Каліфорнійського університету, медичної школи Каліфорнійського університету в Сан-Дієго, зокрема. Тому, Соня, дуже вам дякую, що ви сьогодні відкриєте для нас таємниці моральної травми, де вона ховається, як її лікувати, як її пізнавати і як її переживати разом з пацієнтом. Соня, дуже вам дякую. Професора Ноа Філіпа ви вже знаєте. Ноа є нашим... Where are you? Okay. Він є професор також психіатрії, психотерапії і є фахівцем нейронаук в Браун Юніверситі, медичній школі Браун Юніверситі, і він працював вже з нами минулого разу. Незважаючи на неймовірно щільний графік, він таки вирішив приїхати до нас, подолати тисячі кілометрів для того, щоб знову доторкнутися до наших потреб і дати нам нові знання. Тобто завтра група транскраніальної магнітної стимуляції буде з ним працювати. Дякую, Нова, за вашу жертовність. Новий, але дуже важливий фахівець в нашій галузі – це є асоціативний професор Мартін Арнс. Мартін Арнс є асоціативним професором Мастріх Юніверситі, наш європейць. І тому дуже дякуємо вам. Ми знаємо, що ви вкладаєте величезну кількість свого часу в дослідження нейронаук, зокрема мозку. Ви є засновник і директором фонду Brain Clinics Foundation. І ви будете одним з перших, хто побачить наш центр здоров'я мозку, який ми зовсім недавно відкрили. І ми дуже маємо велику честь, що Нова, ви будете тими вчителями, які дозволять наповнити цей центр знаннями, дослідженнями. І, звичайно, ми будемо з вами корисні для тих людей, хто страждає. Дякую вам. Дуек. Де ви є? Окей. Я завжди це говорю. Я дуже хвилююся, як я це говорю. Для нас дуже з вами спеціальна людина. Хто знає єврит? Я його не знаю. Але я знаю одне слово в євриті. Ор – це світло. І колись я на моїй попередній роботі спілкувався з нашим львівським раби Болт, і він прочитав моє ім'я Березюк ОР, так? Він каже, Березюк Ор, каже, Березюк світло. І я вивчив слово. Нарцистичне задоволення, воно ж працює. І коли ми приїхали на наш перший семінар, Ор, як фахівець, який працює і в Єльському університеті, який зараз працює зараз він повернувся в Ізраїль і працює в Бен-Гуріон університеті. І я бачу Ор. Світло. Для мене було це дуже цікавим. Але цікавим було воно не стільки цікавим, скільки страшним, бо він взяв нас за руку і завів в реальність. Тоді, в червні чи липні 2022 року, під час наших внутрішніх дискусій, деякі з наших психологів говорили: о, війна – це вбивство. Вбивство з одного боку, вбивство з іншого боку. От такі роздуми, сумніви. Гор каже, про що ви говорите? Ваша задача – захистити себе, своє життя, життя своїх рідних, життя своєї держави і своєї нації. Ви маєте думати про це. І це була холодна відро води, але це була ця чесна правда, яка заставила нас думати про те, що ми маємо вижити і перемогти. Тому це було світло пізнання від Ора Дуека. Ор, thank you very much. Ор також є дуже важливим для нас, тому що він є діючий військовий в ізраїльській армії. Його відпустили до нас. І хочу вам сказати, Ор дуже скромна людина, коли під час останнього нападу бойовиків на Ізраїль, Ор і його родина проживає буквально декілька кілометрів від кордону Гази. І і Ізраїлю. І коли я мав навчальний курс в Ізраїлі, був в гостях у ОРа, і ми бачили буквально 2 кілометри газу. Коли настав цей момент, ОР з зброєю в руках захищав свою громаду і захистив. В його громаді не було жертв. Тому ОР є діючий військовий, і його знання для нас критично важливі. Дякую вам дуже, ОР. Новий член команди Девід Розик. Він, де ви є, Девід? Девід приєднався до нас і буде говорити, можливо, про найважчу тему, до якої ми боїмося доторкатися, і поки що не маємо великої кількості досвіду, слава Богу. Це є профілактика, діагностика, профілактика і лікування осіб, що переживають суїцидальні думки або спроби. Тому ваш досвід, Дейвід, буде для нас дуже важливим. Ми все-таки сподіваємося, що ми не будемо ним користуватися, але так виглядає, що так не буде. Тому дякую, Дейвід, що приїхали і витратили свій час. Дорі Рубінштейн – це людина, Дорі, яка також має досвід навчання і сьогодні зараз і працює і роботи в Єльському університеті, але він також спеціалізується в Бен-Гуріон університеті в Ізраїлі, має досвід роботи з ПТСРом і з іншими галузями медицини війни. І він сьогодні для нас, за порадою Ілана, як нашого головного керівника, нам допоможе сформулювати нашу дослідницьку мету. Ситуація, в якій ми є унікальною. І унікальність її в тому, що в попередніх війнах не було потужної наукового середовища, яке могло так зблизька вивчати реакції людей на важку воєнну травму. І, на жаль, ми є цією групою фахівців ментального здоров'я, які маємо цю нагоду, на превеликий жаль. І тому я дуже дякую колегам з Єльського університету, які погодились нас не тільки супроводжувати в пізнанні цього процесу, але й досліджувати цей процес, що стане важливим внеском, нашим спільним внеском в розвиток науки, а найголовніше – це наука, я сподіваюся, зменшить страждання людей, які постраждали від військової травми. Тому дуже дякую, Дорі, за те, що ви приїхали сюди. Тому маємо мету, маємо людей, які готові цю мету реалізувати, і маємо людей, які нам допоможуть до цієї мети дійти швидше і ефективніше. Ілан, few words from you. As a chief from the US.
It's a really great honor for us, all of the team, that you are so here to come and support your struggle. First of all, the bravery and the courage that your country demonstrated is touched so many people around the world, and you know that the Western world, regardless of some leaders, is the people of the Western world really hug you and support you in your struggle. And our team here is really to give as much as we can to you and to help you to continue and grow. You know, there is not just trauma, there is also post-traumatic growth that you learn and grow through the hardship, and you put bandage on the wound and look for a better, stronger Ukraine after this disaster. So we wish this war will end soon, but there is many years after, as we know, after war, that we still need to deal with the aftermath of war. So everybody here are taking an amazing role in this recovery, and all the team here that came today will continue, and we will, every time that all are gonna call, we're gonna come. So thank you for hosting us.
Окей, thank you, Ілан. And, хочу вам сказати, що це а як мені тепер це перейти до Hold on. Цього би не могло статися. Не могло статися, якщо б не люди і організації, які нам допомогли. І ці люди і організації є тут. Без сумніву, це є Воля фонд. Воля фонд – це є організація, яка допомогла нам привезти людей, годувати, проживати. Це дуже важливо. Це лікарі, об'єднані лікарі Єльського університету, Єль університет. Це, беззаперечно, університет Сан-Дієго. Це, беззаперечно, штат В'юзбург, наше місто-побратим, яке нам допомагає. Це Єльський університет, Браун університет і Львівська міська рада, і, беззаперечно, наше з вами перше територіальне медичне об'єднання та UNBROKEN, в тому числі і UNBROKEN University. Тому дякую всім цим колегам за те, що підтримують і допомагають нам пізнавати те, що зменшить або взагалі не дозволить, щоб наші страждання почали нами керувати. Дякую. Я запрошую Ілана до виступу.
So good morning, everyone. What I'm gonna do this morning until lunch is just go and give an overview of post-traumatic stress disorder. So when you see a patient, you can kind of try to conceptualize and frame the work that you're going to do with them. So going over the diagnosis and some neurobiology of the disorder. And I want to thanks also at the Yale University, we created an organization called Doctor United for Ukraine, and we gather a lot of donation, and what we do is we bring physician to Yale, and they stay for a month, and they go through either like emergency medicine, surgery, and now we're going to have psychiatrists coming to do comorbid pain and mental health management. So we really want to support, and those people that comes to Yale and trained, and then they can come back and train your people here. So I want to say thank you to the Doctor United for Ukraine organization at Yale. So post-traumatic stress disorder is kind of the signature mental health disorder of a war, and in the US, and we know now from Ukraine too, but a number that Ole share with you, and even from the war between Israel and Gaza and Hamas, we know that about 20 people out of 100 in the combat develop post-traumatic stress disorder, and this is a really staggering number. Out of any 10 people, 2 of them you will have to treat, and this is a very large amount of people. He's talking about 5 million people exposed to war here in Ukraine. You know, that will be a lot of patients that you will have to work through the upcoming years. So post-traumatic stress disorder is the only disorder that need something to happen to you in order to qualify. You don't need to get depression, anxiety, nothing need to happen to you. So you need to be exposed to directly to something that was death, threaten of death, actual threatened to serious injury, or also we included also sexual violence. And I'm sorry, you don't have, it has to be either directly or you can witness that event. You know, people that watch other people, it can be also now indirectly. This is kind of something that has changed throughout the evolution of the disorder. We know that people that not even directly, when they have someone that's really close relative to them or close friend was exposed to trauma, and that also can affect. There is a lot of work that being done in transgenerational, transmission of trauma. We know that, if your family was exposed, and that's something that prominent, Holocaust survivors or people of that went through a lot of torture, and that's something that really resonate and stay even without indirect. They also included in the new version the repeated and extreme indirect exposure for adverse details. So if you're exposed through your work to, not even directly, but you work in a police or hospital and your team is exposed and they discuss it, or child health, child protective services, they are all talking at lunch and talking, and just that's what's all around you. So repeated extreme indirect exposure to detail can also create a disorder, but it's not by watching TV all the time. That was not qualifier. So kind of this disorder is a tricky one, because I think one of the difficulty for clinicians sometimes there's a clear cut. It's say, okay, this is for sure some PTSD, but we're working with human beings. So even if you're not 100% sure, but you see that the disorder manifests to the fullest, and we'll go over how it looks like, you're can treat it as PTSD, because it's not like we have a blood test measure, or you have you measure temperature and you're above 37 degrees, you have a fever, or you have a blood pressure about certain threshold or certain things. Here it's a man-made construct that we need to deal with. So you want to remember, we're treating human, and what they present in front of you is what you're going to help them to deal with. So there is 4 major clusters of PTSD, and I'm going to talk about them all. So the major one is the intrusion, the repeated feeling that you re-experience at what happened to you. It can upsetting memories of what happened. It can be through nightmares, so people at night reenact and seen from the trauma. You have flashbacks. Flashbacks are people going into a whole, it's a state that they're feeling that they are back in the place that the trauma happened. So it's very intense. I had like a soldier that sometimes he will go under the bed because when there's certain noise, he felt he's back in the battlefield. He's just was so like he was going onto the trenches. It was those are rare, but they are very intense experience. When you see ones, you will see them with people that were exposed to really a lot of grotesque and very intense experiences. You have also what is called emotional or physiological reactivity to reminders. So this is something that's very interesting because it's not spontaneously. It's something that you see something and then your body starts to react. Your body you get very heart racing. You started to feel really sweaty, or you have this kind of semi-panic attack. This your body reacts to a reminder, or it can be a reminder and create really, really negative feelings in yourself. The three first one, and we talked about it, Dr. Dweck and myself really wrote about it. There's maybe two types. One is that require external cue and some other that do not require. And maybe there is different biological mechanisms that drive those two re-experiencing clusters. And sorry, it doesn't move. Okay. The second one in the DSM diagnosis is the avoidance. Those in the first cluster that we say re-experience, you needed only one out of the 5 criteria. Here you need another one in order to qualify for PTSD. So you either have trauma-related thoughts or feeling that you try not to think about it. You're just trying to push any thinking about what happened and not let yourself really deal with it. It's like in the classical repression or denial. You just don't let any feeling in, you just block them. The other way to avoid is just to try to stay away from any reminder, anything that reminds you the trauma. You're not going to watch certain movie, you're not going to go certain places, you're not going to meet certain people. You just avoid doing anything that, in the physical world that might create this re-experiencing. As you remember, because you're going to get this physiological reactivity or emotional reactivity. You just want to keep it away from yourself. This is a way that actually doesn't let your body deal with the trauma. If when things bad happen to us in life, we tend to talk about it, and when you talk about it, you process it. But here, you just because of this tremendous amount of avoidance, you don't let yourself deal. So avoidance is really kind of maintaining the disorder. The third cluster is the negative alternation in mood and cognition, and you can think about it, and I will show it in a second, about, again, 2 systems that works. One is cognition, a lot of thoughts, and the other is more anhedonia, a reward system that really shut down. And you need 2 symptoms of that. So the symptoms, again, is inability to recall feature of the trauma, this kind of amnesia that people, and it's kind of a symptom that is most kind of hard. When you do those large-scale data, this is most of people do not endorse this item. It's rarely endorsed, but it's still in the DSM. Overall negative thoughts and assumption about oneself and the world. You think that the world is a shitty place. You feel that a lot of negative feeling about the self. You have exaggerated blame of self of others. You blame yourself for what happened. Why did I do that? Or you blame other, like your commander. Why did you do that action? If you didn't do that, nothing would happen. Why you took this path? Why you make those decisions? There is a lot of conclusion. And negative affect, those kind of a very negative feeling that bother you all the time. When you see even decreased interest in activity, feeling isolated, and difficulty experience any positive affect, you can think about major depressive disorder, anhedonia. You don't have any pleasure anymore. You lost any motivation to do anything. You just feel emotionally numb. So kind of emotionally numbing. So you have, again, two systems that work that, one maybe will require the numbness and inability to feel any reward, might be more prone to, respond to some medication, whereas the cognition is like working with the therapy to rethink about everything that happened, process those memories, process the situation, more cognitive restructuring approach. And the fourth cluster.
For this translation method, just put you closer at the microphone.
Okay, sorry about it. The fourth cluster, it's alternation and arousal and reactivity. So this is kind of, again, something that people came out of the hypervigilance and hyper startled reactivity. People are very jumpy. That's the signature, most prominent what is arousal and reactivity. But you also have the irritability and aggression and risky and destructive behavior. That's how people find themselves in jail, when they have this inability to control the behavior. So this is kind of aggression, inhibition, control, versus like very fear-based, the jumpiness, looking around, checking if you are safe all the time. This is a system that also play around in this, and you have difficulty in concentration and difficulty in sleeping that is very transdiagnostic. In the DSM, you need to only 2 out of those symptoms in order to meet the criteria for PTSD. So again, we divided like to 3 different systems here: the impulse control, the overgeneralization of fear, and difficulty concentration and difficult sleeping. In order to diagnose PTSD, you need to have those symptoms at least for 1 month. Before this is acute stress reaction. It's a normal bodily reaction that can to trauma. You need the symptoms to go over 1 month. After 1 year, it became what is called, we call chronic PTSD. The disturbance also need to really affect people in social and occupational and other important aspects of life, okay? And it cannot attribute to other effects as substances. So this is kind of the general principle of diagnosis. It's a book, but when you look at the DSM-5, you look at all the possibility, you can have more than 600,000 possibilities to meet diagnosis for PTSD. So if you put 600,000 people in line, each one of them will have a different kind of symptom profile. And this is really kind of very hard to conceptualize, because it's how complex is this disorder and how hard it is to address it. So in our work here, in our laboratory, we really try to, the laser will not work here. We try to look at it as a kind of a different biological systems, okay? So I already mentioned it to you. So you have the intrusion that I put here in yellow, and then you have this avoidance system. We divided again to cognition and anhedonia, and then you have the anger, irritability, and outbursts and reckless behavior, that impulse control. And we have the hypervigilance and exaggerated startle response, that seems to be like what we call anxious arousal system. All your body is really like very hypervigilant, highly activated, and the concentration and sleep problem is another system. So kind of when you look at it biologically and when you're trying to target pharmacologically or psychotherapy, you can think about those systems as operation in a very independent manner, but also linked together. So what are the features that you usually see associated with PTSD? Is sustained interpersonal and family, strained interpersonal and family relationship, altered capacity to function optimal in work and leisure. We have really change in personality, altered worldview, You have survival guilt. Oh, sorry, that's now in Ukraine. So the translation came after the English one. I'm sorry about that. There is the ICD-11, what is the common, and it's very interesting because when we code patient in the hospital, we code ICD-9. We don't code DSM, but actually the ICD-9 doesn't include the alternation in mood and cognition. ICD criteria only include the re-experiencing, avoidance, and hypervigilance criteria. But in ICD-11 also there is the notion of complex PTSD that do include those conceptions. And there is always this kind of I think perception in certain field that complex PTSD is very much like sorry, I'm blacking the word. It's borderline personality disorder. There's kind of this fusion, but you can think about, I'm just as a thought, when you're working in patient with borderline personality disorder, they have this escalation from really admiring someone, and there is instability to the really like unable to, tolerate this person and really denigrate them and hate them, this escalation. Whereas in PTSD, you just cannot trust people. If this person is unsafe, it's unsafe. If there is no like this escalation in the perception of this person between, very admire person to, they doing something and then you escalating to really have negative view of that person. There is more stability in safety feature and inability. But what the ICD looking at, again, is intrusion, avoidance, and hyperarousal for the DSM, but the complex also looking at difficulty in affect regulation. This is tapping into the DSM mood and cognition. Also problem in self-concept and disturbance in personal functioning. So that's something that included in the ICD-11 that is very important and not yet in the DSM-5. As we looked at all those symptoms, it's really like very transdiagnostic and heterogeneous disorder. A lot of overlapping symptoms with depression, as I mentioned, this cognition and the thinking about, negatively about self, other, the words. And you have this anhedonic and reward system that shut down, so there is a lot of overlapping. The hypervigilance, avoidance, is highly prevalent also in anxiety disorder. So when you have this, you give like assessment, you see a lot of comorbidity across those disorders. So you can think about some symptoms that are really adaptive in the war zone and, serving in the military in active duty almost for 10 years and, you in a war zone, you want to be hyper vigilant. You want to make sure that you're not going to, get shot. So you want to see there is enemy around. So keeping yourself hyper vigilant is adaptive. It's going to make you survive. You don't want to shut everything off. But the problem is that when you're coming back, you cannot turn the system off. So a lot of people define PTSD as a failure to recovery from the war. And this is a study that was replicated many, many, many times, is that you see that people without any treatment, if you just people that, this is a study I think done with women victims of rape in the emergency room, and you follow them over time, you see that within a year, the drop of PTSD rate. So after the emergency room, you see about 94% within a week show all the symptoms of PTSD. Without treatment, it's slowly dropping down, and within a year after the trauma, you see around 20% on average that continue to carry PTSD, and that's what the numbers that we're talking about, that we're going to continue to do, and we need to intervene with them. So let's talk about a little bit of risk factors, knowing from the literature what people more put more people at risk, that to continue to have symptoms after the year post the trauma. So the severity of the stressor is, of course, a big predictor of developing PTSD. If you have accompanying physical injury, and we know the number of people here in this horrible war that you experienced, that you have, I mentioned to my team, I read that during the US-Vietnam War, altogether was only like 3,000 people, amputees. Here I think you already like passed 70,000, last time. It's just the staggering numbers of people here that lost one or more limbs. And then it's just unbelievable to know how the suffering here from this war in this country. Deliberately man-made. So if you have a natural disaster like the big earthquakes in China, and people follow the rates of, if it's nature, it's beyond our control. It seems the rates are lower than deliberately man-made event. Exposure to grotesque disfigurement, again, it's the relationship to the severity of the stressor. You have a soldier seeing, bodies, limbs all over, brain, had soldier, talking about, see how they see things after being people shot. This is really like leave a really strong mark on the memory. The severity of initial stress reaction, how people reacted during the event, also have a prediction of who will sustain. Happening in younger age, also a risk factor. Fewer social support, and that's something that I cannot count, because there's so much work, in one of the people in our department, Professor Rob Peterzak, and really done a lot of work on social support, and how social support, even in the military unit support, can create a protective factor. So if even your unit is supportive, and your commander is supportive, and when you're coming back, your community and family is supportive, it really helps to reduce the risk of developing PTSD. So it's really important that you and the community will continue to support those soldiers. And pre-existing history of trauma or abuse, and pre-existing personal or family psychiatric history, all those are things that increase the risk of developing PTSD. I'm going to talk a little bit the etiology, the brain stuff, because this is something that well connect together when we talk about exposure therapy, and how important is to process, and what brain and how the brain acts in this interaction. So, the area that seems to be really implicated in post-traumatic stress disorder are the prefrontal cortex and anterior cingulate, the hippocampus, and the amygdala. There is more areas that involve in the fear, but I would not go into that about other. But those are the major key elements. So the amygdala is like a hub, a small hub, tiny hub, but very important one, of rapid processing. It's detecting the significant kind of, and initiating of responses to emotional, such as fear and anger. So it's kind of like a really like kind of a measure of how stress the reaction is. It's also encoding and storing some emotion memory in it. So some of the memories themselves are encoded there. The prefrontal cortex is the executive functioning, planning, rational decision-making, modulating emotion, and social behavior area of the brain. It's like, and it inhibits the amygdala and helps to extinguish fear. So it's kind of, sometimes you have this counter reaction. The amygdala is starting to process something, danger, dangerous, and then the prefrontal cortex will kick in and say, okay, relax, it's safe. It's kind of putting the brakes on the amygdala. And that's kind of one function that we know that is less active in PTSD. And therefore there is harder difficulties to regulate the amygdala when it's over responsive to the fear. It's giving too much value, although the value is in striatum, but it's giving like the overall over activation of the amygdala. It's say, okay, calm down, and it's less functioning well in PTSD symptoms. Another very important area in the brain is the hippocampus. And it's an area that new learning and short-term memories are working there, contextual learning, and it's really like context. There is a lot of cognitive maps that allows to the context and understanding of where you are in space and times. Also in the hippocampus, it's where our stories of life, the episodic memories are encoded also. And the navigation map, and also helps shut off stress responses too. So that it's also like the connectivity between the hippocampus and the amygdala helps to modulate the responsive to fear. So damage from stress, brain that going through a lot of stress change. It's a very dynamic system. So distress, when it's uncontrollable and unremitted, really create wear and tear in the brain. Okay, and inability, if you are staying like very hypervigilant after the war and very active and cannot shut down, this is kind of similar to prolonged stress that you enduring when you are suffering for PTSD. So this is kind of, if you can look at the brain, after a long time of prolonged stress, there is kind of a loss of dendrite and spines, and it's really creating. You can really look at the brain, and you see that it's really changes. And this is kind of illustration from the hippocampus. What was very interesting in rodent, not in human, they show that if you give ketamine to people, you actually have 24 hours after the infusion of ketamine, you see synaptic growth, both of dendrite spines and branches, actually. So it's called neurogenesis. So we know that some drugs might they can correct some neural damages. And there is some work, again, that we are now trying to see if really ketamine, when it's helping to create neurogenesis, can help to improve, let's say, the treatment of PTSD when you do exposure therapy. One of the major findings that seems to be consistent, that hippocampal volume is smaller in PTSD. It's unclear, I think, yet again, if it's a consequences of the trauma, meaning that, you know, the wear and tears in the brain, and we show that the dendrites and spine that you have and branches that are really started to erode after stress in the hippocampus create like changes in the white matter. You become to have a smaller hippocampus, or this is it's a risk factor. You have a smaller hippocampus, then you're more likely to develop PTSD. We really need like you have to start to follow from childhood someone, and those are very rare. So, but we linked smaller hippocampus. I'm going to talk about something very important. It's called enhanced over consolidation of memory. So when something very strong happens, and it has so much importance to us, it's create kind of a tissue cerebral, like it's creating a mark in the brain. It's everybody probably, if I will ask what did you an American, what you did in 9/11, they will remember what they were and what they did on the same day. Here people will ask where you were in the first day of the war when Russia invaded, because it's so strong, it's so emotionally evoking, it's creating kind of a leave a scar that it's really stay with you forever. So really strong. So we know that animal and human study have showed that emotion arousing events are remembered better than neutral events. In our life, we remember event that occurred when you were very happy, sad, angry, or afraid. And one of the things that fear is forever. Why it's very hard to extinguish fear? So because it has a survival value. Because if I go with my friend O to the jungle and there is a lion and the lion eats, or I don't need to next time that I see a lion to think if I should run away or not. I will run away because it's enough. One exposure. And if your child want to test if the fire is hot and they put their hands in the fire, they need to put it only once. They don't need to try 10 times. So fear, because that's survival, otherwise we will not survive. So that's why it's so hard to change those memories. People see these horrible things and it's engraved in the brain and it's so hard to change it. So biologically, again, why it's engraved so deeply, there is the theory of adrenaline and noradrenaline in the memory. So epinephrine and norepinephrine enhance the consolidation of long-term memory in the process when you're creating a new memory. So the same neurotransmitter that involve in flight and fight. So when you get in a danger, you have a burst of neuroamphetamine in your prefrontal cortex, also help organism to selectively focus on dangerous stimuli and then remember that stimulates better than others. So it's kind of the mechanism that really activate through this, you're getting so hyper reactive. It's also those neurotransmitters that have been released for you to decide, okay, I'm going to run or fight or do or immediately. Then those neurotransmitters also create the consolidation of memory. Traumatic events stimulate release of epinephrine and norepinephrine. And epinephrine and norepinephrine cause over-consolidation of memory for traumatic events, as I mentioned, and they really become really engraved and very hard to change. And those are really the mechanism that kind of lead to the notion of memory are consolidated very, very deeply. But there is a new thinking that involved in the last few decades that human memories, after you created a memory, and this is very important for any psychotherapist because that's how we work in psychotherapy. So the research in the last few decades showed that actually, okay, you created a very strong memory. But when you recall this memory, it's become unstable. Meaning biologically, you can create a change in that memory. And you can interfere in the reconsolidation process. There is a value in forgetting. You ask about, and sometimes clinically things are, if you have a case that has a really very, very bad trauma, do we need to activate it or not? That's a question that you're always struggling with. And I have a soldier that I treated in the past, and there was no PTSD here. He saw gruesome things. He's much more depression in the way. But when I was thinking about what he'd gone through, it just thought this must be PTSD. But he doesn't allow those memory to come into consciousness. He lives with it. He puts it somewhere. Do we need to reactivate it? So there is also some processes that we need to remember. That's an aside, it's not part of the slide. It just came to me because Ole brought something yesterday in terms of clinical. Sometimes forgetting has a value, but we don't want to make mistake as a clinician that we are avoiding because it's too hard for us. It's always this really, really like complex dance when we are as a clinician avoiding because it's too painful for us to deal with it and we're afraid to, or it's okay, the patient had something horrible, but actually they kind of already come into terms with this aspect of the trauma and they have other things that they want to focus on. So that's something that you need to really pay attention to that. That's kind of outside this slide, but it's more clinically relevant and when we talk about prolonged exposure therapy. So when we bring a memory into the consciousness, I say you're becoming unstable and you can change it. It's like kind of a very unique process that's called reconsolidation of memory. So as I mentioned, if I go on the street, I'm being robbed and someone hit me in the head, I'm in the emergency room and then coming and then being released home and I felt on the street that I'm going to die, but then I'm coming and the next day or two I started to talk to my friend about it. And I say, hey, what's stupid? Why did I walk 2 a.m. in the morning downtown New Haven? And you started to joke about it. So you bring the memory that was of the trauma and you started to talk about it. And then suddenly there is humor and understanding and it's become less stressful. The memory changed. The memory never stayed the same. That's what research shows. So it's called memory reconsolidation. You're bringing memory into conscious. Biologically, they prove that it's unstable. If you put if you put an enzyme that interfere in animals in the reconsolidation of the memory, they will not be able to remember. You just stop the memory from reforming again. So it shows that it's every time that it's active, you re-remember it. You're creating the memory all over again, the same biological mechanism. So this is why it's an opportunity to intervene. And traumatic memory one's a problem because we avoid them. We don't want to think about them. So you don't give the brain this opportunity to reconsolidate it. So that's why we think it's important to bring the memory. What's something that was interesting that our group with Oren and we really look at the memory of traumatic memories because the assumption was they are being organized in the hippocampus like other sad memories. I will go, but people like in our laboratory, they talk to or myself and they talk and now they talking to also Dory, and they talk about the memories and they are listening to the memories, the traumatic memories in the MRI. But we compare the activity of the brain, how did this listening to the trauma memory look in the hippocampus while they listen to the memory. And then we looked at if it's like the story play the brain, let's say it's like a music. If you have like different tones, so you can look at the brain activation within this time course. So what really interesting, we found that traumatic memories are not really synchronized between the language and the brain activation in the hippocampus, only sad memories. So we thought traumatic memories are not like a very, 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 very bad sad memories. They're totally different kind of memory. The brain looks at process trauma memory very differently than sad memories. And what we found that they are being processed in the PCC, okay? And this is a totally part of what is called I have blackout for words in English. the default mode network, that where it's like where you are mind wandering, you're like kind of in a state of non-task. And this is the area where the brain really start to formulate autobiographical memories. So what happened is that traumatic memories are disorganized in the hippocampus. They don't have this story, the episodic context as much. They are really fragmented. And they're kind of looking for you, the therapist, to help you to create a story for them, to put them into this area of the brain that is the hippocampus. They can, it will always be said memory. We're not going to make something horrible, funny, or neutral, but it will be a sad, organized memory that have a beginning, middle, and end. It's not going to be like fragmented. Here you have like a flashback to a second that, or you medic trying to save someone, and then you don't remember if this guy is alive or not, and just 1 second here. And it's the trauma memory is very, very fragmented all over. So kind of the psychotherapy that you do helps them to create a new memory. Sad. I cry with my patients sometimes because stories are horrible and it's very hard. But they need to have this cohesive story about what happened to them that they can live with. So talking about the neurobiology, fear condition and fear extinction is the last system that I'm going to talk about. You remember the hypervigilance, like you're jumpy, you're looking around. Also, when you have a reminder, make you feel extremely activated, like the symptoms 4 and 5 in the re-experience, that you have emotion reactivity. We look at it in our work as related to the fear conditioning, and it doesn't change. I don't know why. Okay, so and the overgeneralization of fear, like you take, let's say, a trash can was an improvised. My English is like a bomb in a war. You're going on a street and then the trash can is exploding. Then you're coming back home and you just see any trash bag and you just get very, very anxious and afraid it's a bomb. Even if you are in Lviv, that there's no chance that it will be a bomb, you still have. So it's overgeneralization of fear and inability to shut this off. It's for fear extinction. Okay? And this is coming from like, unfortunately, Russian guy. It's a Pavlov conditional, classical condition. What happens is that you take an animal, let's say, and you play a tone, beep, beep, and then every time there is a beep, you give them a small electric shock to the animal. And then when you stop giving them the shock, you play the tone, the animal body react as the tone predict the shock. The body will react as they receive. Only the beep will create really like increased blood pressure, increased heart rate, respiration, freezing behavior, and stress hormone release that related to fear. So then the beep itself took all the property, the physiological property of the shock, even that there wasn't any electrical shock given. You hear a tone, you say, oh shit, I'm going to get shock. And then you get those fear. So when you experience a trauma, all the aspects of the event are encoded together, okay? And in the context of the environment, it's the visual, auditory, and it's olfactory. The smell also is very, very, very strong experience. So when you have this experience of getting, like what the mice got, electric shock, you get this horrible war experience, that's being encoded together, that's carried out over time. So what we showed in PTSD is that people that are with PTSD compared to people without PTSD, they really have hard time to learn that something is safe again. And they tend, what is very interesting, is to overestimate the information that they get. Meaning that if I go and now I get a shock, next time that I see the car, the trash bag, I overreact. I give too much fear to that. And it's really, really hard for us to get rid of it. One of the best way to deal with it is what is in exposure therapy you do. You're taking the patient and ask them to expose themselves slowly to this environment that is safe. Okay, you say, okay, now you're going to go out to the street and looking at, stay, 100 meters away from a trash can and look at the trash can. And let yourself really habituate and learn to teach your body again that this is, I'm in Lviv, and this is a trash can, and it's normal, and you're not dangerous. You're going to feel extremely hyper-reactive to that, but over time, you start to extinguish this fear that is really important in the exposure therapy paradigm. So when you look at the recommendation for the treatment, and we're going to talk about it like this afternoon, is we're going to talk about exposure therapy. But those analysis, there is a new guideline that already released that I didn't update the slide, but they not change too much. But the most effective treatment for post-traumatic stress disorder is exposure therapy. It's trauma-focused psychotherapy. When you deal with the trauma, you move and you through other techniques, cognitive behavioral processing, prolonged exposure, EMDR, all those things that you are processing and dealing with the trauma to some extent and not avoiding it, you get the most improvement in patient. Very little medication. No drug company really developed a drug specifically for PTSD, because how biologically you can deal with those different systems, how someone can be like very numb and depressed and hyper-vigilant at the same time. So what medication I'm going to give you? Because today you are like this, tomorrow you are like that, and all the cognitive processing. So people like better for the drug company to invest in depression, anxiety, schizophrenia. I don't think in a pipeline there is any company that works directly or develop a compound that will really address PTSD. So the drugs that are being used and approved by the FDA, and there is a lot of more, indicated from other, and we give some psychopharmacology for PTSD here in the past, but currently like fluoxetine, paroxetine, and sertraline are the drug that are being approved for the use. But when you give the antidepressants or monotherapy just by itself without psychotherapy, you have only 30% remission. And psychotherapy, you get between 50 to 60% remission, so you have a higher rate of even just using psychotherapy without medication. So now the field is like going more and more into the combination, when to give the drug, what drugs will, which psychotherapy, kind of trying to tailor the best package for the patient. As a combining, as I mentioned, we're trying to use ketamine currently, not because of the antidepressant effect, but because I think the potential change in the brain can help you to learn better that things are safe and also less stressful. There is a lot of now wave of psychedelics. Probably you heard about the mushroom, psilocybin and MDMA also are all being tested now for PTSD. But biologically, nobody understands how those substances exactly work. But it seems like, let's say, MDMA, ecstasy, people become very talkative. They allow themselves to talk about the trauma that was so hard for them to talk. So suddenly they are more prone. But again, those are drug under investigation, psilocybin, and people are more introspective, more internally. They're thinking more internally. They're not as much talking So, but they say that phenomenally inside they become able to understand themselves better. It's something very internally, but again, there is bad trips. We had some people that talking about very unpleasant experience, and some people had very strong, let's say, flashbacks within psilocybin trial. We have it for depression at Yale, but a lot of people have comorbid. So, you know, everything is you know, we try. Everybody's trying to find the best treatment, but what we know until now that, you know, trauma-focused psychotherapies. This is the safest, more, you know, evidence-based treatment that you can give now to your patient. So definitely, that's the route that you all need to think when you're working with a patient, and then augment with different kind of medication with that if needed. So this is kind of overall kind of how to think about PTSD, because you're going to hear really like amazing talks about how to deal with moral injury and how to deal with suicide. And of course, doing TMS to improve PTSD symptoms is another, you know, frontline work that, you know, Noah and his team is really leading it on. Amazing work. So hopefully you're going to have a very interesting conference today. Thank you.
Thank you, Ілан. Дякую, Ілана. Хочу також сказати, що я згадав всіх і забув згадати, як завжди, про нас, про своїх. Що кафедра психіатрії, психотерапії Львівського національного медичного університету, яка майже в цілому в повному складі сьогодні тут присутня, вона доклалася до організації цього нашого з вами семінару, і також багато працює на сьогоднішній день над пізнанням посттравматичного стресового розладу і розладів. Тому я дякую і нашим колегам, і професору Олександру Фільцу, який обов'язково приєднається до нас протягом цих днів. Це дуже важливо, тому що ми вже готові протягом 3 років нашої роботи, що ми в липні місяці розпочнемо наш власний курс навчання для всіх фахівців, не тільки лікарів, діагностики, розумінню, нейробіології ПТСР та його лікування і інших стресових розладів. Це дуже важливе наше досягнення, що ми за 3 роки пізнали. Я хочу вам сказати, скільки не читаю про ПТСР і про розлади, пов'язані зі стресом війни, скільки не слухаю, кожен раз пізнаю щось нове. Дуже важливим концептом, який ми почали спостерігати, це концепт, власне, діагностичний. І сьогодні Ілан про це говорив, про недосконалість на сьогоднішній день діагностичних протоколів. Це, наприклад, DSM-5 відрізняється від міжнародної класифікації хворіб. І ми також зауважили дефіцит сьогоднішнього визначення ПТСР. Там загалом закладена одна травматична подія, яка викликає череду інших подій і функцій в мозку, і викликає ПТСР. А якщо у пацієнтів таких подій 100 протягом останніх 3 років, 100 зустрічей з смертю, 1 на 1. Що це буде? ПТСР, комплексний ПТСР, чи ще якийсь інший психічний стан? І це наша з вами задача – досліджувати це і пізнавати це, тому що, напевно, воно має вплив, очевидно має вплив, і як з ним працювати – це також є дуже важлива річ. Ще одне, дуже хочеться відрефлектувати на дуже інформовану і конденсовану доповідь Ілана. Декілька страшних досвідів, які ми пережили. В додаткових ознаках, які підсилюють перебіг ПТСР, було каліцтво, яке пов'язане з потворністю. У нас були декілька пацієнтів, які мали шалені травми лицевого черепа. І їхні оперативні втручання робили це неймовірно потворний вигляд. І ще одна дуже цікава річ психологічна, коли для лікаря, щелепно-лицевого хірурга, висліди цієї операції були чудові, і вони справді були чудові з точки зору хірургічної практики, але з точки зору вигляду в дзеркалі, це обличчя було на даний момент потворним. І в пацієнтів були неймовірні депресивні реакції, і на превеликий жаль реакції, які закінчувалися з парасуїцидом чи суїцидом. І тому це дуже серйозно для нас має бути питання бути поруч з хірургом, який заходить в палату і каже: чудесний ефект. Пацієнт дивиться в дзеркало і бачить зовсім іншу людину, яку він ніколи не бачив перед тим. Так само, як вік. Молоді хлопці, яким по 18-20 років, які добровольцями пішли, їхній ПТСР серйозно відрізняється від ПТСР зрілих офіцерів, які пережили, можливо, і навіть важчу психічну травму, ніж це. І хто найбільше оминає розмови про свої переживання? Молоді хлопці і дівчата. Синдром оминання є стержневим синдромом, симптомом. І про що він нам говорить? Чому ми сьогодні всі тут в залі? Ми мусимо бачити це оминання і йти назустріч нашим пацієнтам, бо вони самі не можуть прийти через ці нейробіологічні процеси, які відбуваються в їхньому мозку. Тому так важливо знати цей критерій оминання, тому що це найважливіший критерій. Заходиш в палату, все добре, все чудесно. Задаєш кілька питань, викликаєш довіру і бачиш внутрішнє переживання, внутрішню трагедію. Щодо нейробіології. Велику увагу Ілан приділив гіпокампу. Беззаперечно, гіпокамп страждає дуже серйозно під час того через розрізання нитки пам'яті. Але ми з вами бачили вже емпірично, що коли ми використовуємо знеболюючий ефект кетаміну, а це мікродози кетаміну, так, які не викликають галюциноподібного синдрому, ми бачимо, що пацієнт краще емоційно переносить травму, пацієнт набагато швидше комунікує і є ефективніший в своїй поведінці. І ми бачимо, якщо ми застосовуємо для пацієнта багато параклінічних методів терапії, такі як арт-терапія, терапія глиною, терапія малюнком, терапія спортом, терапія комунікацією, театром, пацієнт також значно швидше починає комунікувати. Що відбувається? А відбувається нейропластичність і нейрогенез. Зокрема, і в гіпокампі, і, зокрема, на сьогоднішній день світ побачив, що нейрогенез вперше був досліджений в гіпокампальній ділянці головного мозку. Тому так важливо розуміти, власне, природу нейробіології для того, щоб якісніше аплікувати інструменти для лікування. Чому це так важливо? Тому що наша кількість наших пацієнтів значно зростає. У нас не вистачить часу довго працювати з ними. Тому ми маємо шукати ефективні і комплексні методи терапії і стабілізації. Сьогодні, після обіду, Ілан зануриться в найефективнішу систему допомоги. Це пролонговану експозиційну терапію. Її неможливо вивчити за один день чи за одну лекцію, але ми з вами формуємо курс, який допоможе вивчати цю дуже важливий інструмент, який потрібен не тільки пацієнтам, але нам з вами, бо ми з вами також будемо піддаватися впливу психотравми від наших пацієнтів. Ми сьогодні говорили, Ілан сьогодні сказав, що є фармакологічне лікування, яке є дуже відносно ефективне. Це 30-20% ефективності. І ми бачимо пацієнтів, які до нас приходять з інших лікарень, де немає психотерапії, вони тільки лікуються фармакологічно. Це не вилікувані пацієнти. Але є психотерапія, яка є дуже ефективна в більшості випадків. Але ще є третій інструмент, який є дуже новим. Це терапія, яка заснована на інструментальному методі нейронаук. Зокрема, нейрофідбек і транскраніальна магнітна стимуляція. І ми в нашій практиці мали неймовірно чудотворні випадки реакції пацієнта на транскраніальну магнітну стимуляцію. Коли пацієнт протягом 5, 6, 10 сесій, дуже коротких сесій інтенсивної транскраніальної магнітної стимуляції, практично залишався без симптоматики, практично був здоровим. Що іноді вводило в неймовірний шок їхніх фізичних реабілітологів та психологів. Тому це дозволить нам більше охопити пацієнтів, дозволить нам зменшити страждання і дозволить нам стати ефективнішими в лікуванні розладів, пов'язаних з воєнною травмою. Тому зараз маю велике задоволення запросити до лекції Ноа Філіпа для того, щоб він нас ввів в курс справи транскраніальної магнітної стимуляції. Це буде його друга лекція в нашій школі. І прошу вас уважно слухати, навіть ті особи, лікарі, чи навіть психологи, дитячі психологи, священники, будь ласка, слухайте, бо ви побачите, яких пацієнтів треба скеровувати на транскраніальну магнітну стимуляцію. Для вас це дуже важливо зрозуміти. Це легка, неінвазивна і нешкідлива процедура, яка може стати підмогою для нас з вами. Noah, more than welcome.
Shall we get the machine in for you? No? No?
No, no?
No.
Okay. Where? 12 to 1. I didn't see it. Where is the lunch?
No, we got it around the corner.
Oh, that'd be great.
Yeah, it's now.
Huh?
13:30.
Okay.
Okay.
I do want to
Okay.
Any time for questions?
Oh, why don't you take some questions while I do this?
Поки Ноа буде готуватися, ви можете, ми маємо декілька хвилин часу для запитань. Можливо, хто має якісь важливі запитання, які би хотіли уточнити в доктора Ілана. Маєте запитання? Рефлексії, просто роздуми, які вас огорнули. Everything so clear. А можна когось з наших колег-техніків до нас вниз підійти? Yeah, he's here.
It's weird. It's a switch.
Yeah, тут треба.
Just need to. Where is this? Oh, USB. Oh, I just didn't see it. Okay. So, no, top one. Well, let's put both in the folder.
Тут зайнято, тут зайнято.
Just copy both. Okay. Yeah. Great. Okay. Do you want a minute, or we're good to go? Okay. Okay. So good morning. My name is Noah Phillip, and I'm coming to you from a very small state in the United States called Rhode Island. And there you heard, right, so I'm a professor of psychiatry. And what I also do is I help teach transcranial magnetic stimulation to our trainees and to doctors all around the country, and help them set up their clinics so that they can learn how to do transcranial magnetic stimulation. What I'm going to do today is tell you a little bit about what it is that we do and how we do it. For those of you who were here in November, some will be the same, but I've also updated some slides, so there's a little bit of different too. And we're going to incorporate a little demonstration in the middle here, which will make it a little bit more interesting, I hope, for all of you. So just a quick comment. Whenever we're giving talks, I always like to mention some of my disclosures. The important thing for everyone here is that there's no commercial or people paying me to say these sorts of things. This is all from me. And I think also, as you heard from Ilan, we're in a, I'm just going to say, unfortunate situation in the United States right now. And it's our pleasure to be here, even though we have all of that that's going on. So we are going to talk through a number of different parts about transcranial magnetic stimulation. And so I hope you can leave here understanding what it is and what it can do. And for those of you who don't do transcranial magnetic stimulation, other clinicians and other people who want to learn, I hope you'll see what it can do, and then hope that you will refer patients for this non-pharmacological, non-medication treatment that works very well. So I'm going to give you a little background on some physics, and then we'll talk about its use in depression. And then I'm going to spend most of my time talking about how I use it in our military veterans, because that's most directly relevant to you here. And then I'll wrap up talking about some of the very neat and exciting things that we have seen in the field recently. Some are a little bit more research, but they are exciting and you should hear about them. So, onwards. And I'm going to apologize to the translator guys up there, because I did change some slides before they saw them. So feel free to yell at me. Okay. Like I said, my goal at home really is to treat depression, treat PTSD. You heard a lot about PTSD from Dr. Arpas Rotem. I don't need to tell you what terrible illnesses these are. But I always like to start with this to remind us that this is why we do this. This is why we're here. And these are illnesses that we all know ruin people's lives. And the treatments that we have for post-traumatic stress just in general are not good enough. And I think we can probably all agree with that. I am a psychiatrist, so most of what I do is prescribe medications, and those just don't work the way we need them to work. We have psychotherapy, which we heard about a little bit previously, and you will hear lots more about. When we come back to the lecture on post-traumatic stress, we're going to talk a lot about how transcranial magnetic stimulation can help that process. We also have things like electroconvulsive therapy and other treatments that are out there that do work quite well, but can be hard to access or hard to use. So within that context, I want to introduce or reintroduce you to transcranial magnetic stimulation. And what this is just very, very simple physics. Here we take a rapidly changing magnetic field, and we use that to induce electrical activity within a conductive media. And that conductive media, just by happenstance of evolution or providence or whatever it is, happens to be between our ears. And that's Michael Faraday there of Faraday's law, which is what I was just describing there. And so to introduce you how we're going to use these physics, the first thing that we do is we take the coil, and there's a time-varying current in the coil here. So that time-varying current generates a time-varying magnetic field. And that magnetic field is the thing that is going to induce current in the conductor. And that conductor is the brain, as we talked about. And as you can see, it requires a lot of electricity. It requires a lot of equipment. And one of the really neat things is that we can now wheel one of these in and show you, whereas previously these machines were very, very large. And if I would turn one on at home and I wasn't careful, the lights would flicker. But now we have them this size. And so whenever we're using magnetic fields, we have to remember that we have to work within their constraints. And so this is a picture that golden halo represents the coil, that sphere is a brain. And that little red bit that you see is where the energy can go into the brain. So we can get a couple of centimeters in, roughly speaking. Now we can get deeper, we can get into different places, but to do that, in general, we have to turn up the energy. And that changes the shape of the field and can also create some safety problems, which we'll talk about later. And so whenever we're talking about using physics and using machines to help people, the first thing that we have to do is we have to figure out where are we going to put our machine, right? Where are we going to put our magnet on the brain to help someone get better? And here I'm going to tell you a story of depression, but this is going to be relevant for many other things. So this is a perfusion scan from the 1980s. For all of the people who are not radiologists in the room, you can probably tell that there's something different going on in the brain of someone who's depressed. So there is a very strong biological basis to what it is that we're talking about. So how do we use this information? And here I'm going to take you through 25 years of functional neuroimage or MRI scan to show you what we'll do with it. So this is what we call a meta-analysis, which is many, many different ways of looking at MRI scans in a single moment. And this is a newer way that we start to think about how the brain is organized, which is lots of different parts of the brain that have to talk to each other to do daily functions that we want them to do. And so looking at this is many, many scans of people who are depressed. And we see two major findings that start to come out. One are the bits in orange. And this is going to be an area that we're going to call the salience network, or a network of areas that helps the brain figure out what is relevant in the outside world. These include the amygdala, which we heard about from Dr. Aparos-Rotem, the insula, and the anterior cingulate cortex. 3 different parts of the brain. The names don't even matter for this purpose. But what they do is they help the brain figure out what's relevant to someone in the outside world. And then On the other side of them, if you will, are areas involved in control or executive function. And here, that's the dorsolateral prefrontal cortex, just right under the forehead here. And a number of other areas, these are depicted in blue in the picture here. And so how is this relevant to depression? So these are all areas that are not functioning appropriately. And so what we have is a series of brain regions that start detecting things in the outside world. They find these negative things in the world to be more relevant to the brain. So when this brain is looking out, when it's depressed, the world is not as good of a place. The glass is always half empty. And then at the same time, we have parts of the brain that are involved in control. You could call it willpower, but executive control. And those areas aren't as well. And so when you put these two together, right, you have a brain that sees things in the outside world that are bad and is not able to regulate that process, that starts to sound a lot like what it feels to be depressed. And of course, the story is much more complicated. Dr. Dudek and others will tell you lots more about that, I am sure. And one of the things that we started looking at this in depression, but once we start looking, we find it in other places too. So we see many of these different networks that are disrupted in depression. And then I want to give you the other example of post-traumatic stress just to show this now, because we're going to come back to it after lunch in the PTSD lecture. And so in PTSD, here instead what we have is we have a series of brain regions that find the world to be threatening. They can't regulate that process. And there's also an internally disrupted sense of one's identity. And just with a little bit of imagination, what these neural networks are doing starts sounding like exactly what our patients are experiencing and what you all have dealt with and listened to on a regular basis. So these are lots of brain scans with lots of pretty pictures, but the neurobiology is directly relevant. Okay. So we're going to go a little bit off script in a minute. So what we're going to do when we have a device, we figured out where we're going to put it. And that's going to be on that dorsolateral prefrontal cortex. It's in all of those pictures that we saw. Go back one, actually. Yeah. So no matter where we look, what illness we examine, we always see problems here in the dorsolateral prefrontal cortex. So that gives us a place to start where we want to put our TMS coil, where we want to change the brain. And so once we've found where we're going to put our device, we have to figure out how we're going to calibrate the device to the person. And we do that with something that's called a motor threshold. And what that is the amount of energy that it takes if we put what we're going to do is we're going to put the coil over the motor cortex. It's the part of the brain that controls your fingers on the other hand. And we're going to figure out how much energy it takes for those fingers to twitch. And that's going to be the calibration that we're going to use for everything else going forward. And so this allows us to tell me how much energy my brain needs, or your brain needs, or anyone who's coming through. And for those of you who did the training with us in November, and who will join over the next couple of days, there's lots of ways that we can calculate these motor thresholds. There are some websites that you can use, and essentially you put in the energy that you're using from a machine, and there's a little algorithm that you watch people, and if you have a finger twitch, you press yes, and if you don't have a finger twitch, you say no. And what you do is you just do this over and over and over again to find out how much energy you want. Why don't I invite the good Dr. Arns up here, or we're going to do a little demonstration of a motor threshold on me, so you all can see what this looks like. I'll sit. So full disclosure, few things. One is I'm okay with doing this. Okay, please don't do this at home if you haven't done it before. Okay. The second of which is I've never been stimulated with this one before, so we're going to see what happens. And so what I'm going to do is I'm going to ask Dr. Arns here to let me walk you through a few things that you just see just before we start. Okay, so there's a number here that represents just a number or how much the machine can give in terms of the energy. And inside of this is a series of capacitors that allow large charges of the electricity to go through the coil here. And I'm not going to put it too close to the microphone because we could fry the microphone. But you should be able to, right? You can hear the clicking, I think. Yeah. Okay. Yeah. Great. And so that's the energy going through copper wires in the machine and eliciting the magnetic field. So actually, what I do in the clinic before I put it on someone's head is I always put it on their arm so that they can see what it feels like. So Dr. Arns, if you want to just put this right, yeah. You all can see my hand moving. Yeah, it feels very strange. Parenthetically, actually, I brought one of these to my daughter's school. She was 12 at the time and did this as a demonstration as well. All right, so we're gonna do this like we do in the clinic. So I'm gonna have a seat down. I'm gonna get. I should. Yeah, thank you. We're gonna. Yeah, and we're gonna keep the microphone away from it too. So let's do. We're gonna do my right hand. So we'll hold it up over here. And so what Dr. Arns is doing is, here, I'm gonna relax my hand here. A little bit farther back. You can turn up the energy. You can turn it up a bit. Yeah, okay. Yeah, you're in the right spot. You can turn it up a little bit more. A little bit more in the back, and you can turn it up a bit. No, maybe a little bit more forward. No. So you can see my, oh, there we go. Watch my, yeah, so watch my fingers. Yeah, everybody can see that? Great. So what I'm also feeling, by the way, in my, I don't know if you guys, for those of you who are close enough, you can see me starting to sweat a little bit because it's a little bit uncomfortable. It's not terrible, but it is weird. And the other thing I'll say is that when we're doing this in the clinic, thank you so much. There's some improvisation in front of all of you here. But when you're doing this, you actually don't really feel your hand moving. Our bodies are used to feeling the outside world with our nerves. We're not used to feeling something that's coming from the inside. And so often my veterans their fingers will be moving over here and they will say, hey doc, I don't feel anything. So I will have them put their hand in front so they can see what's going on. So we're gonna skip this because we got to see it in person. So the next thing that we have to do is we have to figure out where we're going to put the coil so that we can get to the dorsolateral prefrontal cortex. And to do that, we actually have a number of very simple ways. There are very complicated ways that we will use at home, sometimes with MRI scanners and things like that, but we can do actually, we can do it quite well with a simple tape measure. And for those of you who were at the training last time, we practiced this sort of over and over and over again. And what there is a series of websites that are free and accessible. And what you do is you take a series of measurements of an individual's scalp, and that lets us calculate based on their skull where the part where their brain is that we need to be stimulating. And the reason this works is that if, for those of you who have kids or have seen kids growing up, right, as their faces are growing, their brains are growing exactly the same way, just on the inside. And so we can use the shape of their skull in order to predict where their brains are. And we also have a series of some research studies that have shown actually as we do this, we can do this incredibly high precision and also be able to we do incredibly high precision and very reliable over time. And you just put in a series of numbers and it gives you a calculation. And as a reminder for those of you who were last time and for those of you who will be joining us, as we teach you how to do this, you get a certain output where it tells you where to put the tape measure over the prefrontal cortex. And there's a number of different, for those of you who are going to go look at this and play on the website, there's a regular target and an adjusted or a modified target that it gives you with an arrow. And you always want to be using the modified version. It's much more reliable and gets you better clinical outcomes. Okay. So I've talked a lot about magnets, and I've talked a lot about the physics on the outside, but we also have some physics on the inside. So we talked about the conductive media. This is actually my brain. I mean, it's still on the inside, but it's a picture of my brain. And what this is an electrical field map. So we hear warm colors represent, when we put the magnet over my prefrontal cortex, where the energy is going. And so here, warm colors represent high concentrations of electricity, and the cooler colors represent lower concentrations of electricity. When we do some of the training as part of what I also want to talk about is that we've now been able to demonstrate that when we really understand these electrical field models, we can start to predict who can respond to TMS much better. So let's talk a little bit about what happens when we stimulate people. And so this is a perfusion scan from some of our colleagues in Japan a number of years ago at this point. And what that orange blob represents is the change in the brain after we have treated somebody with transcranial magnetic stimulation. So what this shows us is that once we stimulate people, we really are changing the part of the brain that we're targeting. We're changing how it works, and we're changing how it functions. What's also remarkable is that we're not just changing the target, but we're changing lots of other parts of the brain. So just like you saw me there, when my brain was stimulated on my left side, right, my right hand was moving. And so what that tells us, to use some technical terms, is polysynaptic signal transduction. So we're putting energy in one place and it flows through the brain to go down and move my fingers. What this perfusion scan is showing you is that we're seeing the same thing, that when we stimulate at the prefrontal cortex, that when people get better, we're able to change not just the target, but lots of other places in the brain that are highly relevant for depression and for PTSD, as we'll talk about next time. But that idea that the energy has to flow through the brain is critical. Okay. So next, let's talk a little bit about its clinical use. And again, I'm going to be focusing on depression for now. So transcranial magnetic stimulation has been around for some time in the States. I'm going to first start talking about the 2008 version. That picture is not from 2008. This is my, my main nurse that I use for treatments at home. Her name is Callie, and she sends all of you her best. So treatment itself is at a frequency of 10 hertz. That's 10 cycles per second of the machine. We typically use 120% of that finger twitch of the motor threshold. That helps make sure that the energy field is large enough to get all the parts that we want to be getting. And in the very beginning anyway, each session took about 37.5 minutes. It was a long time. But as a nice thing is, it's an outpatient procedure, and so people were able to come in, get their stimulation, and they go home or go back to school or go back to their kids or whatever. So no anesthesia or any other problems, for example, driving afterwards. So this was originally demonstrated in a large randomized controlled trial. Let's try that. Okay. So here are the parameters that I was just talking about before. So this was in 325 individuals, and I want to remind you that these people were medication-free, because at the time we were trying to figure out what was what, right? Was this due to medications? Was it due to other things? And this was what's called a sham-controlled study, meaning that some people got real stimulation and other people got fake stimulation. And this is a really important part about doing this kind of research. So in this design, we had people come in once a day for 6 weeks. And you can imagine that if you're depressed and all of a sudden you're forced, if you will, to get out of bed, come to the clinic, talk to people, we call that behavioral activation, right, for the therapists in the room. And so it was really important for us to demonstrate that the stimulation was helpful over and above just getting out of bed in the morning. And what was shown was essentially, really after about 6 weeks, we had the largest effects of the real stimulation compared to the fake stimulation. And the thing I want to focus on here, I should say two things. First of which is there were stars on the last. Those little stars on the plot mean that it's a statistically significant reduction comparing active versus sham, that this is a difference in depression symptoms over time. And don't worry about the rating scales and the different abbreviations that are there. What's really important, and for those of you who are not going to be doing transcranial magnetic stimulation, this is a really important part to pay attention to. Because one of the things about this is that there's almost no meaningful side effects. So unlike the medications where you can get weight gain, diabetes, sexual side effects, other problems, because we're using a magnet here, the side effects really were largely what you saw. I mean, it felt a little weird on my head. Didn't feel great. My eye hurt a little bit, that kind of stuff. But really not a big deal. And this is very, very different than what we can offer for medications, pardon me. And the reason I also bring this up is as we think about the people who are going to need treatment, right, who are coming back either from captivity or from having trauma in the military, right, we're going to be needing to treat them for a very long time. And so if we can do something that doesn't come with a lot of side effects, this gives us something that we can give them over time, and we can do it safely. Because the last thing that we want to be doing is making things worse. So it's not without risk, of course. So anytime we stimulate the brain, you saw, right? I can make a neuron or a nerve fire. And if we make nerves fire too much, we call that a seizure. So there is always a risk of someone having a seizure whenever we do this. I was very happy that I didn't have one there. But the risk is very, very low. And matter of fact, just to put it in perspective, it is much more dangerous to get into your car or a bus to come to the TMS clinic than it is to ever have a seizure with it. Because we are talking about magnets, there's a few other things we have to think about. So if there's metal in the brain, that can be a problem. So I don't do this in my veterans who have shrapnel either in their brain or in their faces or really above the neckline. Metal can heat or it can move. And both of those options are very bad. Generally, most surgical metal these days is okay. So metal that we put into people for surgeries, by and large, is okay. And even most electronics that we put into people's bodies these days actually are so well shielded that it's okay to use TMS. But this is a case for those of you who are doing transcranial magnetic stimulation that you want to talk to people about and get some consultation. And we can make people manic. So this is for people who have bipolar disorder, they have mania and they have depression, and for some percentage of them, we can make them very manic, and not the good way of manic. So that's something to be avoided. And those two pictures, one, that's an aneurysm clip. So for someone who has a brain aneurysm, that's what the neurosurgeons will put in to make sure the aneurysm doesn't break. And the bottom there is some work I did a number of years ago showing that by the time that you get down to the jaw, there's really almost no magnetic energy. So that's really, really quite safe once you're below that. So there's a couple of very important considerations about using transcranial magnetic stimulation. And these are all things that affect that finger twitch. The first of which are medications. So any medication that can make someone more likely to have a seizure is something we did be thinking about. Any medications that we use to treat seizures, we also have to be thoughtful about. And so, for example, stimulants, these are the amphetamines, make it more likely to have someone have a seizure. So it reduces what we call a seizure threshold, the ability to have a seizure. And benzodiazepines, we have to require more energy to get over what those medications are often doing. Sleep is another consideration. If you get sufficiently deprived of sleep, you can have a seizure. And so, particularly if we're treating people with very bad post-traumatic stress, we want to know what their sleep pattern is, because we need to think about that in terms of our safety. And alcohol can be very complicated here. So when you're intoxicated, when there's too much alcohol, it can act like a benzodiazepine. It makes it less likely to have a seizure. But when you're withdrawing from alcohol, you can shake. That shake is a reflection of how excitable the neurons are, and means that you're likely to have, or more likely to have, a seizure. So when we look at these, it also is a reminder of other substances that are out there. So we struggle often with cocaine or other drugs that are similar to cocaine, other amphetamines. And so we have to be very careful about using stimulation in those situations. Same thing too for many of our patients who struggle with substance use. There are many different kinds of substances that people are using and that are often mixed together. And so we have to be very careful about knowing what our patients are doing and what they're taking so that we can still do this safely. And I would say, just speaking as a clinician for a moment, getting the trust with your patients so they tell you how much drugs or alcohol they're using is a real challenge and is a really important part of what it is that we do. The nice thing is about this is that I talked about all the things that can make it more dangerous. But all we need to do is we just need to know about what's happening. Because if something changes, we just redo the finger twitch. So a patient comes in and they say, "Hey doc, I forgot to take my medications." We just check the finger twitch again. Or it comes in and says, "Hey, I relapsed." We just recheck the finger twitch. So again, getting trust with our patients is a very, very important part. And the nice thing is that we can do something about it and we can still treat them. And as I look at these pictures, I've realized how much I've aged over the last couple of years. Okay, so let me talk to you a little bit about how it works clinically. So here what I'm going to do is I'm going to talk to you about a program that we have in the States where what we have done is we have put a transcranial magnetic stimulation clinic in almost every major veteran medical center in the country. So we have about 85 different sites at this point. And so we have a lot of experience setting up the clinics, training people how to do this, and monitoring outcomes over time. You'll notice on that map, we still don't have a clinic in Hawaii, which I'm really hoping that we can get one of these days so we can go set one up there. This is a picture of Michelle Medor, who is a very dear friend and colleague of mine, who's a neuropsychologist, actually. And she's the main administrator of the program. I'm the medical director, but she is the administrator. And so what I'm going to show you is looking at the number of people that we have treated so far to date using very standard transcranial magnetic stimulation. So just the standard stuff that we've been doing since 2008. And so I'm going to show you two different outcomes. We're going to look first at depression, and then we're going to see a little bit about PTSD, and we'll come back to PTSD in a minute. So this is looking at a depression symptom questionnaire, so the PHQ-9. People start fairly severe, and by the end of it, they're quite a bit better. Are they completely better? No. And we'll talk about actually in a couple of slides ways that we can do even better than this for symptom reduction. But what we can do is we can really get people better. So we can get them better enough that if it wasn't a clinician, you could see that someone looks better just from the door if you were just looking at them. And for the researchers in the room, there's some effect sizes that are up there for those of us who think in that space. And then when we look at the improvements in PTSD, they're also really quite large. So we have on our gold standard scales, we have a very large symptom reduction over time. Again, with effect sizes for those of us who think in effect sizes rather than actual numbers. And this was the first 770 people that we treated. Now we're at 3,000 or so. So it's quite a lot of people. And it's worth saying, so was this safe in these people? The simple answer is yes. We had one person who had a seizure that was using a machine that is more likely to have seizures, and so that's not a machine that we generally start a clinic off with. We had 6 people get worse when they were getting TMS. Anytime that we're treating things, we hope it always gets better, but sometimes it doesn't. Although 6 people out of 770, it's pretty good. We had 2 people who had heart attacks when they were sitting in the chair. Nothing to do with TMS, but it happened. And actually, even though I was very worried about mania based on early days, we actually never made anybody manic in more recent use. So very, very, very safe to be doing. And we're going to see if this video works. I want to see if we can get some of my patients to talk to us. You know what? The sound's not going to work, but that's okay. I'm going to narrate what he's doing, and then we can translate it. So this is Bill. He's one of our Vietnam patients. And what he was saying there was that TMS was, he actually wasn't saying it made him feel not depressed. What he was saying was that he was able to get back to his life. Matter of fact, he didn't really care that he wasn't feeling as depressed. What he cared about was that he was able to participate in his world. The other thing I'll say is that Bill's wife came and found me on the side and told me that whatever I was doing, I had brought her husband back and he was no longer a jerk. And whenever the wife says that, I know I'm doing something right. Okay, so a few other things, and this is going to get more to the people who are doing transcranial magnetic stimulation, but it's still interesting for the rest of you to hear about. The first of which is, actually, I'm going to take a step back. So when we look at those 770 individuals, roughly what we see is that we can get about 2/3 of them better in some form or another. And 1/3 of them are really quite a bit better. And then what we had to do is we had to figure out, once we get someone better, what do we do? And so what we looked at is what's called maintenance TMS, or giving stimulation over time to help keep people well. And so we did a randomized controlled trial now a couple of years ago. And the short version of the story is that we either gave them stimulation on a regular basis, or we waited for them to get worse, pardon me. And it didn't really matter which one we were doing. So we don't generally recommend doing maintenance TMS, at least infrequently. What does work, though, I want to highlight, is the success of retreatment there, which is at 80%. So if you respond once to this, the odds that it's going to work again in the future for you is extremely high. And that's a really important message of hope that you can give to your patients. And also, when we treat people again in the future, it happens much faster. So the brain has learned to respond to this, And so we don't need to do as much the second time, which is really nice. So what does this mean? This means that I have a whole bunch of patients that will usually call me around a trauma anniversary or a tough time of year. Christmas is a very, unfortunately, popular time for treatment. And so they'll say, hey, doc, I'm not feeling so good. I get them right in, and we retreat them and get them better quickly. And for those of you who are doing transcranial magnetic stimulation in your clinics, what I do now is I set aside a part of my day that's just for retreatment. Because once you have enough people who are treated over time, the last thing that you want to do is not be able to treat somebody when they really need it. So actually, I keep about a third of the day openings in the clinic for retreatment so we can get people back in as fast as possible. Okay. So the last part that I want to do here is walk you through some of the really neat and exciting things, some advances that we've seen over the last couple of years. The first of which is something that we call theta burst stimulation. And what this is we're trying to now match some of the patterns of the energy with some of the patterns that the brain has going on the inside, particularly in the hippocampus. And what this does is it allows us to give larger amounts of energy in shorter periods of time. I think in the interest of time, I'm going to skip through this, but suffice it to say what we can do is if we give a little bit of stimulation, we can give a lot in a short period of time, and actually the effects start to last. So we stimulate the brain and we can measure at least an hour or two later, and we can still see the effects, which is really important. So this allows us to start thinking about how we want to use it clinically. This is a large study that came from some of our colleagues in Canada. And what they did was they used regular TMS, which was 37.5 minutes, once a day for 6 weeks. And they compared this to this newer kind of TMS called theta burst. This took 3 minutes. And what they found was that sitting in the chair for 37 minutes and sitting in the chair for 3 minutes got you the same thing. And this now starts to let us be a lot more creative in how we're going to use our stimulation. We can start treating a lot more people in a short period of time. Or as you'll see as we go forward, we can start adding a lot of stimulation in a week or even in a day. So this is some work I want to highlight from one of our friends, Nolan Williams, who's at Stanford. And what he did was he came up with a new way of putting lots of stimulation together, where essentially on the first day of getting treatment, you got the equivalent of an entire 6-week course of stimulation. Now, this is a long day, but it allows us to start giving an enormous amount of stimulation in a very, very short period of time. And so he gave a little bit of stimulation, and then he gave people a break, about an hour. Stimulation, a little bit of break, about an hour, and onwards. And what he showed to look at these plots, comparing real stimulation versus fake stimulation, is that in a single week, we could get people better from their depression in 5 days, as opposed to waiting for 6 weeks, which is what we've been doing for years. And so now what we're talking about is we're talking about the use of stimulation to get people better very, very fast. The other thing I want to highlight is you heard a little bit about plasticity or brain changes in Dr. Alvarez Rotem's talk about with ketamine. There is an emerging idea that we might be able to use certain kinds of medications that makes a brain more likely to grow and put it together with TMS. And so this, and don't worry about the details of the protocol, but essentially it was a single day, 1 day of stimulation, very long day, but 1 single day of stimulation. And right before stimulation, 2 different medications that can help the brain grow. One is called D-cycloserine, which is actually a very old medication that we use for tuberculosis, and some amphetamines of a single dose, so not enough that we're going to worry about drug abuse or things like that. And when you added those 2 together before the day's worth of stimulation, this is in 32 people, and this is 1 day of stimulation, and what that curve is going down over time is their depression. And so after a single day, right, you can see depression is going down for the next 12 weeks and actually continues to get better over time. So we're not just getting people better, but we're actually changing the process by which their brain is doing things, right? There continues to be improved wellness over time. And that's a really, really exciting option. This is very new. But the reason I bring it up is that this is essentially doing standard transcranial magnetic stimulation for a single day combined with some very simple and very safe medications. So I do want to say I've talked about transcranial magnetic stimulation for depression here. There are lots of other uses. There are many different settings on the machines that we can use for TMS, we can make them a little bit shorter. We can change the frequency of the stimulation. There's lots of different things that we can change. We'll talk about PTSD in the next lecture. We're also going to talk about using it to reduce suicidal thoughts and suicidal behaviors. We're going to do that next time too. There is an emerging literature on using it to rehabilitate after traumatic brain injury, and also in motor recovery. And I know we've had some conversations with folks here about this over time. So I've talked to you about it in terms of depression, right? But this is actually a tool this is a tool to change how people's brains are working and help restore them to health. And so with that, right, so I'm going to wrap it up because I'm mindful that I'm between you and your next meal, right? I've taught you about some of the physics of what it is that we do. I talked about its clinical uses, and particularly in populations that are similar to what we treat here, and some recent advances. And just before I wrap up, so I am deeply grateful to be here. I am the one giving this kind of talk, but I'm deeply mindful of an enormous number of people and funding and other organizations that have to be here to make all this possible. And so this is some of my team at home. I think with that, I will wrap up. My contact information is there in terms of email or social media. If you do email me, please use like Translate GPT or something, because my Ukrainian is terrible. I'm still trying. But thank you very much for your attention.
Martin, would you like to add something? Your thoughts, visions?
No, I think great overview, but...
No, but just probably some reflections or no? Я хочу сказати thank you very much. Ми, можливо, приступимо до запитань, якщо будуть, але зараз я хочу сказати, що Мартін важливу справу зробив, не тільки приїхав разом з НОА для того, щоб нам провести навчальний курс, але Мартін взяв участь в великому фандрайзингу і разом з собою привіз 2 апарати транскраніальної магнітної стимуляції. Тому, Мартін, дуже вам дякую. Один з тих апаратів є апарат, який є переносний, і ми тепер можемо це робити і для тих пацієнтів, які в нас є немобільні в зв'язку з оперативними втручаннями, ми це можемо робити в палатах. Тому it's a great effect. Дякую вам. Дуже, як бачите, Нова сказав дуже важливу річ. Іноді симптоми депресії чи інших розладів залишаються, але люди відчувають значне покращення якості життя. І не тільки пацієнти це відчувають, але і їхні родини. І ми з вами, як психотерапевти, психологи, психіатри, соціальні працівники, досягаємо одного дуже важливого ефекту. Ми досягаємо покращення якості життя, що наша є основна наша задача. Покращити якість життя, а не знизити симптоми. Іноді симптоми значно приємніші, ніж життя, яке є навколо. Тому, шановні колеги, маємо декілька хвилин часу. Ваші запитання, якщо ви маєте, ваші сумніви, якщо ви маєте, ваші рефлексії, якщо ви маєте, думаю, ви повинні їх мати. Я би хотів, щоб ви використали цей момент, дати запитання і Ілану, і Ноа, і Мартіну. Будь ласка.
Hey, sorry for my English, but I'm asking about potential risks of increasing seizures with adding lisdexamfetamine 1 hour before TMS. Yes.
So thank you for the question. And I suspect that, right, you're a physician or in training. And so I just want to unpack how good of a question that was for people who don't think about medications. So the medication that she was talking about is the amphetamine given right before that whole day of stimulation, right? And as I mentioned, right, anytime that you give, if you're using medications like that, you have to be very careful about the motor threshold over time. This particular formulation is a longer release so that we can anticipate that over the course of the day that the motor threshold won't be changing. If people are using very short forms of stimulants with very short half-lives, we have to be very careful about that kind of stuff. And we're actually going to talk about this a lot in the PTSD lecture. I'm going to walk you through what I do for accelerated TMS, kind of from the clinical workflow. And so we do have to be careful about it. And what she's highlighting with this question is that if you're starting TMS, the thing to do is not to start by adding lots of other meds with it. Stick to something very simple first, get good with it, and then you can start adding in other items. But the really important part is that if there's short-acting amphetamines or cocaine or other things like that, then it can get very dangerous very quickly. Thank you. Yeah.
Дякую. Ще, будь ласка, запитання? Будь ласка.
Доброго дня. Я хотів спитати, чи мігрує ділянка, яку потрібно стимулювати, якщо є багаторазові ураження черепно-мозкові?
So that's a great question, right? And so to unpack that a little bit, right? So the front part of the brain is often the one that is injured when people have traumatic brain injuries, particularly if they've been in vehicle injuries or with explosions. And so we have a couple of options in those situations. If there is a traumatic brain injury to the spot that we're stimulating, I generally do not treat over the injured location. I will usually treat on the other side. There's also some settings that I will use that are a little bit safer. So lower frequency protocols in that case are the ones that I use. And we can talk more in detail about it. There's a slow frequency stimulation. It's 1 pulse per second. And I will do that on the side away from the injury. And that's generally a much more safer option for those individuals. I will say that, and I'll show you this data this afternoon, TMS still works quite well, though, when people have had brain injuries. So as long as it's safe to do so, it still works very well. Great. Thank you.
Ще запитання? Не тільки до Ноа, але, можливо, до Ілана. Будь ласка.
Скажіть, будь ласка, чи, от, наприклад, мій чоловік повернувся з війни, ну, він ще не повернувся, але він зараз тут, і він мав контузію, і в нього є отакий писк в ухах. Чи можливо оцей метод ТМС якось буде на це впливати, чи, ну, можливе покращення? Дякую.
So thank you. So that's a question about tinnitus, is what so the ringing in the ears after an injury. It works okay. It's not amazing, but it certainly does work. There's a number of different ways that you can stimulate it. Actually, stimulating with a standard spot works okay for tinnitus. And for some people, if it's very difficult to treat tinnitus, there are some different locations closer to the back of the head that we can stimulate. Again, usually in a slower frequency, but not always. I want to caution, just because it's to give you reasonable expectations of these things. It does help reduce the bothersomeness of the tinnitus. They don't always describe that it's less loud, but just it doesn't interfere with everything that's going on. So they can still hear it, usually either they're still hearing it, but it's just not as bothersome. To your point about sort of quality of, not always about symptoms, but it's a sort of a quality of life improvement.
Ще? Ми будемо сьогодні також говорити про коморбідну патологію, так? ПТСР і контузії в народі, комоційна травма, посткомоційний синдром. Це дуже важливі ускладнюючі фактори, зокрема в лікарняному просторі, такому як наш, де у нас травма госпіталь. Чи є ще якісь запитання? Будь ласка. Рефлексії, так, будь ласка. Що МВС хоче, ми даємо завжди слово.
Дуже дякую. Моє питання до Ілона, і воно стосується того, що ми говорили сьогодні про нейровізуалізацію при діагностиці ПТСР. А підкажіть, будь ласка, які саме методи ви використовуєте під час діагностики? Чи ви опираєтесь виключно на якісь емоційні показники, поведінкові показники і так далі? Дякую.
So today, the most common use is the clinician-administered PTSD checklist. It's CAPS. It's by interviewing the patient, going through the events, and making determination based on the DSM. So we use a clinical interview, and I don't know if the CAPS was...
Yes.
So that's the most commonly used. There's no physiological biomarker that are being used. There is some studies being done across the globe that they're trying to do the clinical interview, blood test, and imaging, but we don't have this precision. And again, so the best way to approach it is still clinical interview with a clinician, but following the question correctly is very important, and that's what will help again. And you don't have to go over all the traumas. People have hundreds sometimes, and also apply. I will talk about it in the treatments. Sometimes you just walk and take the one that is most bothersome, maybe all of them. So just take one and go with it. And again, it's very important the patient will feel the alliance and make it, otherwise they minimize. Some soldiers do minimize. We did some military culture training here before. It's very understand that I think one, it's important for all of us that did not serve in the military is to let the patient lead you, that they teach you about what they happen. It's empowering for them sometimes. If you let them, before you started the clinical interview, just tell me about the military, ask questions. If you don't understand something, just ask. You know, make sure that you're interested and don't dismiss anything, because every military occupation is different. Every role is different. A driver, someone that put the artillery into the cannon, everything is totally different. Everybody is different.
Medics, the special.
Medics especially, and medics, from my experience, and I don't know, or are working through like very standard operation procedures. They're working like a machine and following things, and sometimes they are in disconnect, and then when they realize what happened, it's really like hit them hard. Yeah, so yeah, definitely go and try to understand what was your role, what you go and give time to create this relationship that they can trust you and tell you everything.
Дякую. Я хочу доповнити невеличку річ. Ми пробували, зараз нам ОР допоможе, напевно, обстежувати велику кількість, ну невелику, відносно велику кількість пацієнтів, які мають діагноз ПТСР з допомогою ФМРТ. Так, ми отримали цей апарат і трошки з ним працювали, досліджували і вчилися. І ми побачили дуже цікаво, це обсервація, це не дослідження, так, що у пацієнтів, у яких є діагноз ПТСР, часами ми бачимо картину реакції, так, ми бачимо активацію мигдалини і візуальної кори, зону Бродмана, але не бачили жодного сигналу з префронтальної кори. А іноді ті ж інші пацієнти, які мають також виражені симптоми посттравматичного стресового розладу, але не мають такої картини. Так? Вже мають префронтальну кору і не мають мигдалини, але мають симптоми. Тобто це багато цікавого нас чекає досліджувати. Ще одна цікава річ, що пацієнти, які поступають і обстежуються за допомогою PCL5, PHQ9, GAT7 і клінічного інтерв'ю, КАПС – дуже важливе інтерв'ю, і можна швидко навчитися його робити. Але вони мають симптоми і мають позитивні висліди на шкалах. Через 4 тижні, 5 тижнів лікування вони мають якісне покращення життя, і ти не бачиш симптомів, а на PSL5, PHQ9 і GAT7 симптоматика не знизилась в цифрах. І наступає таке як розчарування. Як так? Так гарно все виглядає, а цифри залишаються ті самі. Це також феномен того, що якість життя покращується, а симптоми далі залишаються. Дуже цікаві спостереження, я думаю, ми будемо ще сьогодні про це говорити. Ще? У мене є запитання до Ноа. Ноа, чи є дослідження, чи спроби поєднувати, чи Мартін, поєднувати лікувальні процедури, наприклад, транскраніальна магнітна стимуляція та експозиційна терапія. І якщо є вони, то які там результати? Чи вони пришвидшують лікувальний процес, чи швидше змінюється якість життя?
Can I say stay tuned until after lunch? Yeah. So there's a lot that we have done, and often it's helpful, but it can be unhelpful. And so how these are put together does need some careful consideration. I will say that one of the things I always do after we're done stimulating and treating people is if they're not in therapy, we get them right into therapy. Because this often lets them approach things that are difficult to address otherwise. And if you can just get people better enough that they're able to talk about it, then sometimes you can do things in therapy there that were not previously possible. And so we will often get very difficult to treat people with depression or PTSD or whatever. And we will do our treatment, and I will only start the treatment once I know that they can get into like a residential or intensive therapy program, so that we can get them better, and then they can immediately use their brain being better in therapy. What I always tell people is that I don't have a magnet that's big enough to solve your problems in life. Right? What this does is it helps your brain work in a more normal and healthy way so that you can then participate, so you can go to therapy, so you can talk to your family or your children. And that's what this is. I showed you lots of pictures of changing the brain, and that's the purpose of changing the brain. So to your question, we certainly do put them together. And there are certain ways that can be helpful, and there are certain ways, though, that we can actually make people worse, which I'm going to talk about this afternoon. So tell you what not to do, so you can learn from some of our experiences. But again, I think I always get people. We stimulate them and right into therapy if they're not in it already.
Дякую. Це дуже важливе питання і ще важливіша відповідь, тому що стигма психіатрії, психотерапії залишається достатньо великою в нашому суспільстві. Через те, що ми мали такий досвід штрафуючої психіатрії, колоніальної психіатрії. І тому застосування непсихіатричних методів, бо дуже часто, ви знаєте, пацієнти кажуть, ні, не треба до мене говорити, дякую, в мене кукушка не поїхала. Так? І оминають. І тому запровадження такої непсихіатричної, неінвазивної, інструментальної методики зменшує стигматизацію процесу. І я дуже тішуся, що я почув те, що деколи транскраніальна магнітна стимуляція є ініціацією психотерапії, яка вже безпосередньо працює. Це дуже важливий компонент і важливий момент. Ще є? Можна, звичайно, можна. Так. Я хочу також сказати, що дуже важлива була слайд в НОА, слайд великої кількості надавачів послуг транскраніальної магнітної стимуляції в Сполучених Штатах Америки. Для нас це дуже важливо. Це дуже технічно проста справа зараз. Ти натискаєш кнопочку і не треба більше нічого робити. Можуть бути декілька лікарів, які будуть допомагати аналізувати ці речі, але технічні працівники, які навчаться це робити дуже швидко, можуть це робити будь-де. Це може бути в поліклініках, це може бути в монастирях, це може бути в військових клубах, які будуть все більше і більше організовуватися. Це може бути будь-де. Це є доступна, легка, нешкідлива інтервенція. І тому для нас дуже важливо, це і недорога, так? І для нас це дуже важливо, щоб чим більше людей знали про це. Так? Я був шалено збентежений позитивно, коли я приїхав в монастир на Волині. Як називається це село? Вжидичівський монастир біля Луцька, 3 кілометри. І знаєте, яка там була служба? На базі монастиря, і монахи нею займалися? Я в шоці був. ДСНС, 2 пожежні машини, якими оперують, тобто в селі, в громаді монастир виконує функцію ДСНС. Будь-який монастир, будь-яка поліклініка, будь-який солдатський воєнний клуб може оперувати транскраніальною терапією після того, як вони пройдуть певні курси і навчання. І досягнуть умови з лікарями, які будуть їх супервізувати. Це не моя фантазія. Я переконаний, що це наше майбутнє, і воно почалося вже минулого разу, коли НОА і інші колеги до нас приїхали і почали працювати. Тому дякую вам. Я хочу сказати, що в цьому залі присутні майбутні професори, і доктори наук в цій галузі. Це доктор Шпильовий, він вже кандидат медичних наук, який працює з транскраніальною магнітною стимуляцією вже декілька років, був піонером на Львівщині. Це доктор Заневич, невролог наш, який зараз вже працює більше року. І це доктор Задорожний, який також активно працює. Ну, вони мають ще інше завдання, вони не мають тільки лікувати і вчитися, вони вже мають вчити. Тому їхнє горе прийшло до них, і тому будемо разом з тим. Окей, якщо немає ургентних запитань, вони можуть бути перекладені до післяобіду. Нас після обіду чекає дуже дві важливі теми. Це безпосереднє використання транскраніальної магнітної стимуляції для лікування посттравматичних травматичних стресових розладів. І друге – це пролонгована експозиційна терапія з елементами коморбідності, яка буде представлена доктором Іланом. Ми маємо трошки довшу вечерю. Господи Боже, хочеться вже вечері, бачите, ще не попрацював. Це 14:30, ми зустрічаємося тут без запізнень. Окей? Дякую вам. Запрошуємо вас пригоститися питвом і наїдками, які є поруч.
Let's
Sounds good.
take a picture together because maybe it will not be